Good morning. Today I just really wanted to talk a little bit about the National HIV/AIDS strategy and specifically pre-exposure prophylaxis. The strategy was mentioned last night. Many of you in the room have already read the strategy, know quite a bit about it. It was released 3 years ago. This World AIDS Day, the White House is going to be releasing the first quantitative report updating where we are in reaching the goals of the National HIV/AIDS strategy. Over the previous 2 years, we've released more qualitative evaluations of what the federal government is doing to reach the goals of the National HIV/AIDS strategy. So we figured at this point, it's a nice interim before the 2015 goals are reached for the strategy that we could just give people an idea of where we are in reaching those goals. So please do look out for that. As you also know, in terms of the strategy, that there are a couple of things that we placed in the strategy that are directly relevant to the meeting that we're having today in terms of treatment as prevention as well as pre-exposure prophylaxis. The first and foremost is that in pulling together the strategy, we made sure that we had buy-in from a wide array of federal agencies. NIH and CDC were integral to the development of the strategy. And what is very clear when you actually take a look through the document is that we specifically mentioned both pre-exposure prophylaxis as well as treatment as prevention as specific modalities that would be added to the HIV prevention armamentarium if those issues prove to be effective. So that's already explicitly written into the strategy, and you could see with the HIV Care Continuum initiative that was just launched by the White House earlier this summer that we're moving forward in that direction as well, and to really try and hone in on those specific issues. The strategy also mentions explicitly the disease burden among men who have sex with men as well as transgender populations. And I really can't understate how important that is. There has never been a White House document that has said explicitly that you would never be able to turn around the HIV epidemic nationally without effectively addressing and stemming HIV infections among men who have sex with men. So it has been very clear about that, and the president has discussed that on many occasions about reducing new infections among men who have sex with men. The third thing that we have in the strategy that's also relevant to this discussion is to take a look at some of the disparities that we see in infection in specific communities and in targeting men who have sex with men and making sure that we have increased rates of viral suppression specifically among men who have sex with men. So those are three things that are definitely related to what we've been doing in terms of the National HIV/AIDS strategy and what the strategy has for us that's specific to this meeting. In terms of what the government has done over the last 3 years since the release of the strategy, there have been several things, some that have been mentioned already during the meeting. We were integrally involved in the FDA approval and use of Truvada for PrEP. We, of course, were involved in some of the guidances that have come out through PrEP from CDC and clearing each one of those guidances. We are in the process of pulling together some modeling studies. I think I mentioned this last night that CDC is modeling PrEP, pre-exposure prophylaxis, and HIV risk transmission per contact probability for MSM and other modalities for HIV prevention just to see what those contact probabilities might be. We're in the process of pulling together those analyses, and that's going to be released in a paper that's going to come out perhaps next year. And there are additional PrEP studies, of course, that are taking place that TRIP and many others have discussed this morning from the federal government and funded by both CDC and NIH. And last, there's quite a bit of interest as well as research that's taking place in terms of long-acting agents for pre-exposure prophylaxis and really making something like that come to fruition. The other thing that the federal government is doing, and specifically what Office of National AIDS Policy is doing that is really important, is having meetings. One thing that can't be understated is the power of the White House to convene meetings. You say that you are inviting someone to come to the White House. It's amazing how folks are able to jump to come to meetings. I have to admit there have been a couple of calls that I made to Hollywood, and I was amazed with some stars and their agents who were able to give us some information that was really helpful to help help proselytize about how important it is to get tested for HIV. But some of the meetings that we've had have been, directly related to HIV and GLBT populations. So for instance, last year we had a meeting at Howard University to highlight what's taking place among black men who have sex with men and HIV, as well as homophobia in the black community, and to really discuss those efforts and try and figure out how we might obviate some of those issues that we're seeing. This year, there was a meeting that from another White House office looking at ACA and GLBT communities that Kellen Baker here in this room chaired. And we also had a meeting during Creating Change with GLBT leaders and GLBT organizations that are not specifically involved in HIV work to help re-engage them in the fight against HIV and to provide a lot of the data that I showed you last night in terms of increasing HIV incidence among men who have sex with men. So this is really a long way for me to say that instead of me giving a formal presentation, what I'd like to do is to utilize the rest of the time to get information from many of you, because there's so much collective wisdom here in this room that I could potentially bring back to both HHS as well as the White House in terms of specific policies, programs, or research that really needs to be done around pre-exposure prophylaxis. As I mentioned before, there are specific things that the Office of National AIDS Policy can do. We can mobilize agencies around important issues. We can order reports through the Institute of Medicine that might be helpful for providers as well as others. It usually gets quite a bit of coverage. And we can host meetings to help elevate a specific issue. So I was curious to see, among some of the comments, what are some of the things that might rise to the top in terms of recommendations, policy, research, or program that you would like for me to bring back to the White House as well as HHS that's central to the goals of this meeting?
Yeah, hi Greg, Jim Rooney from Gilead. Research dollars for the CDC would be great. They obviously were key funders of some of the pivotal trials that helped establish the efficacy of PrEP, the Botswana TDF2 trial in particular, and the IDU study in Bangkok, the demonstration project in the US that provided important safety data in MSM, but they have no funding available for demonstration projects to tackle some of the questions that this group's trying to address today. So some money for that would be great.
Thanks. Greg, decisions from the NIH about moving forward with research agenda and which sites were funded for certain networks just came out. And so all the 6 major networks, including the HIV Prevention Trials Network, the HPTN, be worth looking at the list of sites. This is confidential information, so none of us know actually which sites were funded and which sites weren't, but the rumor on the street is that there was no expansion of HPTN, and in fact a contraction of HPTN sites. So I would urge you to take a look at that, because who is going to push the research agenda in terms of PrEP except for these sites?
Yeah, so Greg, we know that the U.S. Preventive Service Task Force took more than 6 years to go from the CDC recommending routine HIV testing for Americans aged 13 to 64 years of age. There are now multiple trials showing the efficacy of PrEP, and it needs to have a grade A or grade B recommendation for the U.S. Preventive Service Task Force with the ACA. So I think trying to understand their process for making decisions, seeing if it can be expedited would be helpful.
Related to that, I think that an early part of moving HIV treatment along was also doing analysis and the financial analysis about savings over time, not just our DALYs, but actual expenditures in the system. I think when you look at formularies that are restricted in so many ways in the exchanges and all in terms of tiering and limitations in class, how you get this one in, and what the strategy is, what are the aligned kinds of other. I'm not convinced that the use last night of birth control as an analogous circumstance is such a useful one, but I think that we're going to need some, and we're going to need dollars saved and expenditure patterns that align with other chronic illnesses.
I like to recommend sort of like a national roundtable with all the medical, nurses, social workers in the White House, with Secretary Sebelius, the Director of Domestic Policy, on how the important for all these associations to change curriculums in terms of all the issues that we raised today, but also on how to reduce stigma and especially homophobia. And on a separate note, I think the same purpose, a national media roundtable with all the networks and so on to create a national conversation.
Jen Cates, Kaiser Family Foundation. I was going to say a similar thing, which is, has the White House used its power of convening to bring together medical school leadership, potentially even in a private meeting with your office and the Office of Public Engagement, to talk about the importance of culturally sensitive care for the LGBT community and people with HIV? I think that would go a long way. And then secondly, on the issue of HRSA and CDC working together, given that, at least looking specifically at HIV among MSM and transgender communities, that there's a national challenge, but there are certainly locations in the U.S. where the most people are living, and we can identify those. So if HRSA and CDC come together and really focus energies and attention both on the spectrum, the care continuum, and including prevention, including PrEP, including all of the things we've heard about in specific communities, I think we can get a lot further along the line.
John Manuel Andriot, journalist. We know and have known for more than 30 years that gay and bisexual men, or men who have sex with men, comprise the majority of new HIV infections as well as those living with HIV. Yet we also know every analysis that has been done by the CDC, Fenway also did an analysis showing that despite the fact that MSM account for the largest percentage of the epidemic, we have received the lowest percentage of HIV prevention dollars. Will there be an effort under the national strategy to allocate proportionate prevention funding to target the proportion of the epidemic that MSM account for?
Actually, I just want to answer that one really quickly. Actually, when you take a look through the strategy, that's one of the things that we placed in there specifically, is that resources need to follow the epidemic, and you need to target those populations at greatest risk for HIV. And when we released the strategy, we also released a document from HHS for the first time, actually breaking down by risk group and categories where the funding is, a proportion of funding for research as well as program across the federal government. And we're looking forward to doing that again in an updated manner very soon.
Hi, Greg. 3 general areas for suggestion. First of all, you heard both FQHCs and hospitals, anything that the federal government can do using levers to give teeth to the routine screening recommendation, indicators, publishing indicators, licensing, regulation of hospitals. Anything you can do could be very, very helpful, even working with risk managers at hospitals. As far as CDC, you heard that Laura Cheever mentioned that Ryan White ADAP cannot pay for PrEP. CDC, while strongly recommending PrEP, does not pay for the medication. So this becomes kind of a catch-22, particularly for uninsured individuals. That would be very, very helpful. And lastly, as we transition from, or shift in some ways from Ryan White to Affordable Care Act and broader insurance, this notion of health homes becoming more than health homes in name only, but they really provide the true wraparound services that Ryan White has done very, very well in, so that we don't lose ground. Those would be 3 areas.
Yeah, thanks, Greg. I have 2 things. First, I'd love it if you guys could use the power of convening to get some of the medical associations at the table to talk about all of these areas, and make sure that the right ones are at the table, just because the right people for screening might be different than the right people for treatment as prevention, might be different than the right people for PrEP. So getting those right people at the table would be great. And then the other thing, and I know you don't have this power, but I think language is really important, and I hope this doesn't seem esoteric, but every time I hear behavioral prevention, my spine just gets all in a bunch, because taking a pill is behavior, and we just still need to work on these behaviors with people in prevention. So language is important, so think about that.
Thanks, Greg. I would like to see the White House take more initiative around lifting up some of the projects that have been very successful, working within extremely difficult some of the psychosocial issues that were raised earlier, for instance. So if there are some community-based projects, pilot projects that could use additional funding or additional exposure or opportunities for us to learn from what works really well within deeply marginalized communities and be able to just amplify those opportunities with additional research and funding.
Hi, thanks. I'm going to come at it a little differently. And since community health centers are the cornerstone of many of these national initiatives, I think most of the dollars that are being released, health centers don't have access to, and they're training dollars, they are not capacity building. And the things that are really in a primary care system that the White House and the bigger agencies can leverage are clinical decision support systems that are uniform data collection so we can actually submit the data. There's a lot of parallel play and infrastructure problems that are waste in the system. Because the funding isn't aligned, and so to work across the agencies and perhaps do something through the CMMI innovation centers and incentivize communities and not organizations, because people live in communities and they're part of bigger systems. So I would come at it with a little different approach, and really to the innovation model. I think we are a design. We are all designers in a new system of care, and that we keep bandaging the old system, and that system doesn't work for this population or this disease. So I think we need new funding streams. Thanks for capacity building and not necessarily training.